Dear students, we'll discuss a topic which is quite common, especially in alcoholic patient, rather distressing and life-threatening, even though it is benign. That is, just see this one. See that? So much enlarged, dilated veins you can see here. You can see the umbilicus here, hernia is there. Massive ascites. See that? Massive ascites with dilated veins in the abdominal wall. With the umbilical hernia here, you can see the umbilical hernia. You can see the dilated vein here. And probably due to portal hypertension. Here, problems are respiratory distress, umbilical hernia, and spontaneous bacterial peritonitis. SBP, it's very, very common, remember, especially in a patient with cirrhosis. And they need a long-term antibiotic. Usually, norfloxacin once a day is given, preferably mainly by the medical gastroenterologist and hepatologists, which is said to prevent the recurrent SBP, which is often becomes severe and life-threatening also. Serum ascites albumin gradient, SAH, is a very important accurate investigation to confirm ascites is portal hypertension. When it is more than 1:1, that is very determinant for the portal hypertension. So what is the portal hypertension? It is a sustained elevation of portal venous pressure more than 10 mm mercury. Again, MCQ question. Normal portal venous pressure is 5 to 10 mm mercury. Remember, it is defined as elevation of the hepatic venous pressure gradient, SVPG, more than 5 mm. Again, MCQ question. Hepatic venous pressure gradient. HVPG is the difference between the wedge hepatic venous pressure, where you pass a catheter, fine catheter interventionally, and goes and wedges the balloon is inflated and wedges the hepatic vein, wedge venous pressure. And free hepatic venous pressure, once balloon is deflated, that is called a free hepatic venous pressure. So this is what is hepatic venous pressure gradient? It is the difference between the wedge portal venous pressure and free hepatic venous pressure. Free is deflating the balloon, the small balloon than the tip. After with inflation, it is called wedges the venules or terminal veins or small veins. That is exactly meaning. Wedge venous pressure means balloon wedges. So remember, examine the patient completely. Look for splenomegaly. Anasarca is very common. Edema everywhere. Lot of fluid overload. Pleural effusion is common. Respiratory distress is common. Other features of liver failure. Hepatic encephalopathy with the drowsiness, and you won't remember. And along with that, hyponatremia also common. In encephalopathy, ammonia will be very high, serum ammonia. So CEC to abdomen, alpha-fetoprotein, because it may turn into malignancy, hepatocellular carcinoma, hematocrit, liver function test is essential. Blood creatinine sometimes, so they'll have renal failure also, like something like, not exactly, but something like hepatorenal syndrome or dehydration or reduced output. Prothrombin time, APTT also important. Hepatic venous pressure gradient, I already told what exactly meaning. Serum ammonia is important to find out encephalopathy. Acidic fluid tap is very essential. And serum acetic albumin gradient, very accurate method I already told. Gastroscopy should be done for varices. So all these things are attributed, so you need to admit the patient, assess the patient. Many times they go for sepsis, renal failure, hepatic failure, encephalopathy. So many problems are there. So one by one you have to assess them, you have to give the albumin to this patient. To contain ammonia, there are many drugs are there. So child Turcotte pug classification and grading for the severity of cirrhosis is to be assessed. They are commonly asked short note, MCQs, Viva, they will put oxy, they will ask. So you have to know that. Please go through my SRB manual of surgery, and also it is there in the clinical methods in surgery. This table is very, very important. Go through that. And management of portal hypertension, general measures, anemia correction, albumin transfusion, nutrition important, blood central line is required, blood product, drugs to reduce the portal pressure like propranolol, nadolol, isosorbate mononitrate, so many drugs are there. And varices management, either sclerotherapy, not that common, banding, sclerotherapy, balloon tamponade, shunt surgeries, devascularization procedures, tips, transjugular intrahepatic portal venous shunting, that is mainly as a bridge to in future liver transplantation, because eventually they require liver transplantation as a final treatment modality. That is the important thing you have to remember. Initially tapping, salt and fluid restriction, spironolactone is very good. Leave-in de novo peritoneal shunt often is done to the IJV. Tips I already told is a bridge for liver transplantation. Liver transplantation is the eventual ideal requirement to save the patient. That is the most important thing. Of course, alpha fetoprotein should be done, CT should be done, because it may turn into malignancy also. And the dread death, life survival is very minimal in such a patient. It is the point you have to remember. So, detailed portal hypertension, my book, Manual of Surgery, the liver chapter with illustrations, photos, banding, varices, ascites, different methods, gradients, meaning, evaluation methods, everything is given in detail in understandable manner. Please go through my Manual of Surgery. Of course, how to examine such patient is given in my clinical methods of surgery, different ascites, how to manage puddle sign in small ascites, then fluid thrill and percussion, ascitic management, ascites checking actually, fluid displacement. So, that is there in my book. Please go through that. Clinical methods in surgery also. So, students, answer the MCQ. I will acknowledge and appreciate your answer in comment box. So, for transjugular intrahepatic portosystemic shunt tips, minimum size of the tent required is 8 mm, 12 mm, 16 mm, 20 mm. Please answer the MCQ. Please. Second MCQ is, which of the following procedures used as selective shunt for portal hypertension? Side-to-side portocable shunt, proximal splenorenal shunt, distal splenorenal shunt, mesenterico-caval shunt. Please put the right answer in the comment box. I will acknowledge and appreciate you. So, quotation of the day, students, you don't get paid for the hour you have spent, but you get paid for the value you bring to your hour. So, value of your work is more important than just timing, what just spent the time. So, whatever you do, it should be valued properly. Then only you are eligible to take the return for that. That is the exact meaning of this. Students, please go through my SRB's Manual of Surgery, SRB's Clinical Methods in Surgery, and SRB's Operative Surgery, Surgical Atlas. The new edition has come, and Atlas of Steering Technique. Manual gives everything in detail about all topics as per CBM syllabus: general surgery, gastrosurgery, urology, neurosurgery, cardiothoracic, and basic instruments, specimens, brief operative surgery, which is essential for UGs. Everything is covered with the quotations, with the illustrations, the diagrams, photos, covered everything as per CBM syllabus. And clinical methods in surgery, current edition gives you proper clinical idea, approaches to all cases, briefly orthopedic also. Again, it contains instruments, specimen, images also, and videos. Each chapter videos are there, how to examine a patient, which is very important when you do a practical exam, clinical exam. So, very, very useful, everything, with again, lot of photos and proper methodology of examination with the differential diagnosis tables are given. So, it will be very, very useful. Of course, operative surgery is a very detailed, 2-volume, extensive book with more than 10,000 photos and illustrations. Whenever you want to, any surgery, including specialty, general surgeries, gastrosurgery mainly, in detail it is given. It will be very, very useful. So, students, also go through my SRB's Surgery Insight YouTube Insights, and please subscribe for all these lectures, daily lectures for brief 6 to 10 minutes, and live sessions once a week or once in 2 weeks I am doing. They are also very, very useful for students with very, with the interaction with the senior faculties are there, and always they can answer your doubts and through chat. So, please subscribe my channel, YouTube, Instagram to have a better knowledge and increase your surgical knowledge as such, because it is free also. And my DigiNow lectures through JP, around 220 lectures covering everything surgery, including specialty, operative surgery, clinical methods also, with the videos through JP Publishers. And you can always purchase that one for 1 year, so that you can have go through all lectures with a very clear idea about the subject to face any exam, including NEET or final year exam or even PG exams. So, I hope students, you have understood this topic, massive ascites, very well. Thank you so much.